Good evening, friends, and very warm. And it's very cold in North India, but still, I would say it's a very warm welcome to each and everyone for joining us today for the very first, discussion on actionable evidence-based practices. And these documents are from Patient Safety Movement Foundation USA, with whom we collaborate for this Annie Patient Safety Fellowship that we started in 20. The first cohort had passed out already 2023. The second cohort will pass out in 2024, and the third cohort will pass out in 2025. So, primarily to be driven by the cohort 3, supported by cohort 1 and 2, these monthly sessions are going to deep dive into these documents which have been released by Patient Safety Movement Foundation USA. And if we don't look at evidence which is available out there, we will not be doing justice to our patients. Evidence-based practices are brought after in-depth, search of whatever research findings which are there, study findings, many different associations, they come together. That is how PSMF, or the Patient Safety Movement Foundation, they release this actionable evidence-based practices. So it is worthwhile that all of us, learn things from there and take it back to our organizations to improve patient safety for our patients. So once again, a very, very warm welcome. Give me a minute before I hand over the session. Okay, so these are our monthly learning sessions, and we are starting in January and we will go out throughout the year. And this is going to be brought by Annie Patient Safety Fellows. And as I already mentioned, the documents that they are going to discuss are actionable evidence-based practices from Patient Safety Movement Foundation USA. In collaboration with them only, we are running this fellowship. And so we are hoping that all of you will come back every month to learn on different topics. So we are starting this month with culture of safety, because that is the umbrella for all the safety initiatives that are going to be taken in hospital. So that's the calendar for you for the 2024. You can see from January to December, we have 12 topics which are going to be discussed by different patient safety fellows, and these are their deliverables because this is a fellowship program. So they do things, and through that they learn and they share learning. So this is just for you to have a look at what is evidence-based practice. So, evidence based practice comes up when it's a process of reviewing, analyzing, translating latest scientific evidence. We don't have many evidence based practices coming out of India, even guidelines. All these things come out when the associations or bodies or group of individuals, they come together, they study these things in depth, and then they come up with recommendations to say that this, if you do these things together, you will get better results. Similarly, like our care bundles, CLAPSI bundles, COTI bundles, all these bundles are being created. If you do things together, then you get the deliverables. You don't get if you do only one item from the bundle. Similarly, all these recommendations from PSMF, they talk about doing many things together to achieve. Today's topic is of safety. So I also looked into what is the definition for EBP in nursing. So evidence-based practice in nursing again involves holistic quality care based on most up-to-date research and knowledge rather than traditional methods, advice from colleagues or personal beliefs. So many a times when I take my sessions, I usually tell them, this is not me telling. This is evidence that is speaking. You cannot go and tell it's because Tankam ma'am told or people told. No, we are reproducing evidence which is available and bringing to you. Maybe we don't have enough time to go and read all these documents. So we are doing this free because we believe Association of Nurse Executives India believes that we are there to empower nurses and to empower nursing practices. And this is one of the ways that we are contributing. So today it is going to be primarily driven by KS Neetu. She's an ANI Patient Safety Fellow of 2023. And she's also Nursing Superintendent Quality in Digitalization, Rajagiri Hospital, Kochi, Kerala. I will be supporting her, and all of you know me. I don't need to tell more about myself. I'm very happy to be initiating. I volunteered that, I will do it with her. So in February, the topic is going to be standardized and safeguard medication administration. That is going to be dealt with Lieutenant Colonel Amita Nees, Patient Safety Fellow of 2325, and Ms. Purba Das, Patient Safety Fellow of 2224. So, with that, ladies and gentlemen, thank you for being here. And we hope that you will travel with us throughout the year to empower yourself with evidence based, which is out there, the practices to make sure that our patients are safer, our practices are safer. With that, thank you so much. And once again, welcome. And I request Neetu to start your discussion, and I will pitch in wherever I need to pitch in. Over to you, Neetu. Thank you.
Thank you so much, ma'am. So a very warm, sorry, ma'am. Yeah, you can hear me, right? Yeah. Okay. A very warm good evening to all of you. It's my immense pleasure that I'm the first speaker of this cohort 3. In this distinguished gathering, I'm actually presenting the Patients Fellowship, Safety Fellowship, which is sponsored by Patient Safety Movement Foundation in association with AEBP. So my sincere gratitude and thanks to the organizer and the mentor, our beloved Ms. Tangam Gomez, for providing us with this invaluable platform to discuss about the major thing about of a patient's safety. Our commitment towards the patient safety is not only that we do things, we read things. It is actually implementing that evidence-based practices on the ground. So with that, I'm just pitching into my topic, that is just culture, the culture of safety. Just a minute, I'm just sharing my screen. I hope my PPT is visible. Thank you, ma'am. So with this, the webinar on the topic of culture of safety, we are going to learn today is about how we are create a safety culture for us, for the patient, for the workers around us. So with that, the objective of the program, the first objective is understanding the impact of safety culture. We need to, how we are gonna go with the safety culture, the patient safety, their challenges and the concerns which we daily faces. The objective 3 will be the component of safety culture. What will be the major components which we are going to discuss today? And of course, the leadership role. Never ever, nothing in a hospital, if we talk about implementing something, leadership role is very major. With that, what is safety culture? What we understand with this? What is actually meant for the one who are at bedside, meant for the people who are coming to the organization? There are different aspects of patient safety culture people are having with. And for understanding that as well, I have done a small survey. In between, I just tell you about the stories during my survey, which I heard from my different colleagues, starting from the security guard till my nurses to the housekeeping to the pharmacy in a different role people. Before that, the patient safety culture is basically nothing else, the belief and the norms and the values which our organization is expecting from a healthcare worker, which they are putting up for the safe culture of the patient, for the safety of the patient. Basically, we are how we are rewarded for that, supported and expected and accept that beliefs and norms, and how we are implementing those things in a multiple levels. It is not only about one person or one department, it is actually about whole system. It is the belief that how the hospital is implementing the values which they are working for the patient safety, the departments and the units how they are contributing to it, and the extent which they can take up that culture in at every level in the same way. That is how the safety culture develops. That is the meaning of safety culture. Of course, when we talk about safety, patient safety, there are a lot of challenges and the concerns daily everybody is facing. First thing, that recognizing the errors, difficulty in recognizing errors. So sometimes people don't understand what is actually the error is, or what is the deviation of the process. Whether we are deviating the process will give a shortcut to the things, but they don't land up into the they land up into the errors, but they are unable to recognize whether it's a error actually happened. Second is lack of information uh, in the system to identify the errors. So, of course, once a person is joining the hospital, they get induction. After induction, there will be in the nursing. Actually, we will have a continuous induction program for further days. Like if I talk about my hospital right now, where I'm working in Rajagiri Hospital. So in my hospital, we have some around 2 months training period in which they are actually doing a classroom session. After that, they were working as a preceptive. So to understand that, the, identify the error at each level, how they can get the knowledge. So these are the things where they are getting awareness about. Coming to the third challenge is the relationship of trust with providers. Of course, when we are coming to the hospital, the patient is having a lot of trust in us. We need to be like what we are exactly supposed to give to the patient. What care we supposed to provide to the patient? Are we really relating with that care? What the patient is expecting, and also we are following all the perspective which we supposed to follow. The shortage of clinical professionals. So I must say that there are shortage of clinical professionals. Like basically, if coming to the today's scenario, the experienced clinical professionals are very less, which cause some around a chaos to understand the process are going with a proper format or not. Then the fifth point is concern about liabilities. Of course, when a person is usually won't address any error or incident because they think that it is my liability again to implement those things or to improve. If I report this thing, it will come on me. It's like a reporting some cases into the police and police is behind you. So that's the way the people usually think that quality people will screw me to take the concern in lighting. Sixth is limited the capacity on how to use quality improvement tools such as PDSA, that is a normal common tool which we are using to improve our quality perspectives. So there is a limitations to understand about the implementation of such tools in our projects. And seventh one is the culture of patient safety is lacking. That is the main thing. Like we develop everything, we create things to understand by the care professionals, but still there is a gap between the implementation. That is where we are lacking to create such kind of a culture. Uh, Ma'am, you want to pitch in with the concerns and challenge from your experiences?
Yeah, I think you have summarized the points well, but from my personal experience, I would say that the major problem that we are facing today is that we talk a lot about patient safety. We talk a lot about culture. But when you enter the system, you don't see the culture. You don't even see the climate because it takes years to set in a culture where everybody is talking patient safety, whether it is nurses or GDAs or doctors or the front office, everyone is worried about the patient safety. It's a common belief. That's what you discussed in the previous slide. And coming back to nursing specifically, I think we are doing a lot of training. We are trying to give a lot of information, but then whether that information is explained, I would say that the why part is very important. The why part of anything is very important. What is important, but if the person does not know why, then the person will not do it all the time. See, almost all hospitals have their value, integrity as one value, where they say doing right things when no one is watching. So recently I've had been exposed to hospitals and I had become a consumer. Sad but true, I don't see. Forget the culture. Even people practicing safe measures, which are very, very basic. they are not there. So I keep wondering that why is it happening? And I remember that you were telling that, we do have a preceptive program, but the preceptor themselves are very young. Now, this is something repeatedly written even in US also, that the preceptors are very young, they have not had enough experience. So again, I think that today's day and time, with the many different challenges, we all understand all these things that we are talking about. How do we make our healthcare workers accountable for what they are doing, genuinely becoming serious about what they are doing, why they are doing. So I would always summarize that it's a responsibility for all nurse leaders, educators, and everyone to explain the why part of it. Because I happened to be in the hospital, I explained to the night duty nurse about scrub the hub because she was not scrubbing the hub of my mother. When I explained to her why is it important that she has to do it, vulnerability of a 84-year-old female. When everything I explained, she was quiet and then she said, I learned all this, but no one to explain this to me like this. This was the answer I got. Okay. So there is a lot that we need to think out of box to see that how can we educate. And there is a need to educate these youngsters very quickly to do everything. That is also a challenge. So between all these challenges which are there, each one of us have to make that commitment that whatever we do will have to end in safe care. That is important. I remember one of the CEOs a few years ago told, the culture will take at least 3 years. When you consistently do something for 3 years, everybody is talking, everybody is, doing the same thing, then the culture can set in. But you can change the climate little faster. Yes, the sunny
True.
day, rainy day, the climate you can turn faster, but for that you need champion. I really hope the people who are attending today and the people who are going to watch this recording later will at least make a commitment to themselves that I am going to be a patient safety champion. Let's not find excuses for what is not happening. Can I tell myself that I'm going to do the best to ensure that it becomes a safe care for my patient, whichever role that we are doing? Thank you, Neetu. Please continue.
Thank you, ma'am. It's actually, yeah, when you said that those things you can relate with actual scenarios which is we are facing on the daily basis. True, with the role of being me as a nursing superintendent for quality, I have seen my people like how challenges being faced by the trainers as well as my specialty as well as the head nurses at the bedside whose experience are not getting the. Okay, moving forward with the components of safety culture, of course, there are multiple components. We are going to discuss about the 5 components which majorly indulge with the safety of culture, safety culture which we are expecting at bedside. First is the create the trust, ensure accountability, identify unsafe conditions, strengthen the system, and also assess and continuously improve the safety culture. We'll go one by one. With the create trust, the word itself is saying that we need to create a trust in the working environment where we are working with. For that, of course, who will be the best person to play the role? The seniors, the leaders. We actually learn everything when we see our leaders. So, as I always appreciate the leaders I worked with, and currently I work with a very down to earth person, and I really appreciate that she actually is a person who's trying to give a role model for others. She deal with people with in such a way that to understand what is exactly happening at the ground level, then only we can create such kind of environment that people will believe in you. And that's how we're supposed to work. That's why if it is a physician, if a senior physician is following a hand hygiene practice, for example, of course they will learn and assess, oh, sir is doing, of course it is very important thing to prevent the infection in the patient. So that's how the seniors usually create a trusting environment, and among the staff they become a role model for them to, so that they can intimidate that, yeah, this is the right practice I supposed to do. Coming to the committee, family advisory, the patient and family advisory committee, because as you know, the patient safety culture is not only the responsibility of only the healthcare workers, which is also the people who are around the patient and the patient itself, because we are giving lot of educations to the patient. Like for example, I see my as I said to you that I done a survey, a small survey with my nurses and as well as different roles. So just now with this statement, I just was relating this thing with my nurse who told me that I have a full authority, full empowerment to teach my patient about fall prevention measures. Usually, the fall prevention measures, once a patient is admitted in the ward, it is very important factor when, especially when the patient is inside the room. So you teach everything. You tell the rationales as well to the patient as well as the family member, but till the time they are not follow it, it is actually not implementing in that level. That is a challenge which you usually face. So we have to create such kind of uh, a committee or a person who's like dealt with such kind of issues which comes during when we are dealing with the patient directly. They actually help us to help the patient and the family members, because they become very rigid about that. Like we are okay, we have no issues. If side rails are down also, we have no issues. But these are the maybe the advisory committees can play a very crucial role in making the patient and patient family to understand the importance of those things. Coming to the third point, that we have to create a feel safe environment, the safe environment for the working people, which is actually a major factor for nowadays. Because if everybody remember, like few days back or few past months back, we have heard lot of news about the doctors are beaten up by the patient bystander, the nurses are dealt by them, like such kind of issues we have dealt with. And of course, so for that thing, if something has been done with the patient also, we have heard about in the news. So preventing such kind of a harm to self as well as to my patient, I should know that how to report such things, how to work around those things. Yes, ma'am. So on putting up some light on this create trust, I'm just expect telling Nanga ma'am, please tell us some stories about the experience you have dealt with.
See, there are a lot many stories. I would only say that, all these things that you're talking about. In India, recently, KAHO has floated, patient family advisory council that every hospital will create. So we are taking the right steps which are available as evidence. Okay. The challenge again is back to leaders. How much of verbose we are and how much of action we are. There is a disconnect between what we know, what we write, and what we implement. So it is very, very correct that role models are lacking. So my experience, recent experience was also that. So now there is a new word that I read is the new PPE. So everyone knows PPE as personal protective equipment. The new PPE is, professional practice environment. Are we able to create professional practice environment? I mean, this is very, very important. So if you ever travel to abroad, and same, our own nurses are working abroad, you will see that professionalism is very different from how they are behaving in India. So, my dear friends, while we are talking about all this, there is a responsibility on each one of us to be at the highest, behavior of professionalism in communication, in dealing with others. So there's a lot of responsibility lying on the nurse leaders. I'm not talking about only the CNOs. Every educator, clinical instructor, any role that we take, others are watching us. Whether we can lead them, give them that environment to trust. Like just now you said, the staff should feel comfortable to report, So when they report, how we deal with them will decide whether they will report again or not. Even your body language. If someone says that, I'm sorry that I made this medication error, and you say, oh my God, once again, then that's it. I mean, that's a very unprofessional behavior. Theoretically, everyone knows that how we are supposed to deal when someone comes and reports to us an error. But in real life, are we kind enough to listen? And it's also very important to remember creating trust in current generation is not done the way that we have experienced earlier. It is very, very important to remember the Gen X and now the Gen Y, millennials, they all are different. If there is a disconnect, I have a millennial Gen X, that category sitting at home, that's my son. So if there is a disconnect between what you speak and what you practice, immediately they will understand and your trust is gone. So I would only again summarize what you have told is that all of us have a responsibility to be a role model to the next person next to us or working with us or working under us. It is very important that we role model what is required to be practiced so that we can create this, new PPE that is, professional practice environment. Thank you, Neetu.
Okay, thank you, ma'am. With that, the second component, the major one, is like creating and ensuring that accountability for what we have implemented. Of course, once a trust has been built up, the people will understand the reason why these things are happened or why these things need to be implemented. And once I know that, yeah, this is my responsibility, I am accountable for this. I just wanted to take one example of my specialty nurses. Like right now I'm getting very new people in my team with the different roles because that role is new for them as well. I have infusion nurse, I have tissue viability nurse. This is quite new for my system right now. We just have a one diabetic nurse, so there are different kind of people coming with the different disciplinaries, different level of working they had before. But right now they're coupling up with some role is like I am responsible. If I talk about my tissue viability, yeah, she says that I am responsible for making a safe environment. A skin should not get any happy. Patient should not get any happy, and if the patient is coming with happy, should not get worsen. That is my responsibility to teach each and every person so that my organization will be free from such kind of a thing. And when we talk about any care, any implementation, if it is equitable, like it is not differentiating what is a doctor is doing, it is not, it is okay for everybody. But if a nurse do something or a housekeeping do something, we have to take action. No, it should be transparent, equitable, and uniform for each and every role so that the people will understand, yes, we are all are treated equally, and of course, all are accountable for the processes which is implemented at our organization. Coming to the shared responsibility for maintaining a culture, of course, it's a multidisciplinary team which we have at bedside or multidisciplinary team working around the patient in the hospital. All are having their own roles. They have to act accordingly. If they share their responsibility equally and very transparently, they definitely will create such kind of a culture. If people are approachable, it is very easy to share the things which is happening at bedside so that we can improve, we can process. Because actually the people who are working at the bed, working in the field is the real checker for the things, whether the things are rightly happening or not. Implementing just culture. So has been started with that same word only, creating a culture. Ma'am has already said it take 3 years to create a culture in a particular uh, organization which is working with different kind of a people, different thought of the people, with the different generation as well. So that's how it's supposed to be created. Like just culture. If, I do remember my induction day when I just started my induction. My HR has asked everybody, "What do you mean by just culture?" So everybody know this is a JCI hospital. Of course, just culture is very important part of it. Just culture is like we should be safe. Our patients should be safe. That's the only thing that everybody was dictating. Then when we went into the detailing of that just culture, my HR was actually asking me that you should explain about this because you are the quality person. You are actually dealing with these kind of a thing. Then I just spoke about my to the people that actually it is not only keeping you safe and your patient safe, it is also speaking about the wrong things which is happening at around you without fearing of anything that uh, people will be having any punitive action. No, nothing. Just culture is such culture working environment where everybody has freedom to speak about the safety, whether it is related to your own healthcare professional, whether it's all about your patient. So that kind of a culture is very important when we talk about the ensuring that accountability only comes with that culture, because once you give a freedom to talk about the wrong things happening at bedside, and you give actual uh, the improvement measures to improve such kind of a things, then only people will believe and create such kind of environment. Yes, ma'am, over to you with the enlightening of this accountability towards the patient safety.
I like to recall, our current president, Captain Ajita, has got a very interesting word she uses in her talks. It is called accountability paralysis. People, they want recognition, they want power, they want designation, they want everything, but they don't want to take accountability. So, in a just culture, everyone takes their role seriously. So, in there are some, what you call characteristics of a just culture. So, just culture is a learning culture. So, this it just culture will have a learning culture that everybody is learning, and it's a reporting culture. That means just now you said everybody is empowered to report any unsafe practices. So, you can report and you learn from them, and it is non punitive. That is how it becomes a just culture. Yes, it is definitely for safe practices, but the just culture has got another component which talks about doing taking action where it is required. It is not that everybody reports, everybody has to report, but the people are told beforehand, different types of actions, negligence, or there are different definitions for that, so they are aware. But then I am accountable for reporting unsafe practice being done by my colleague if I see. So if I don't report, then that culture is not anymore just. It is just for the patients. It's fair to the patient. It is fair to the employees, fair to the guests who are coming into the hospital. So it is fair for everyone. So it can only happen if you are learning, if you are reporting, and you are not punitive for every reporting that happens. Yet you're accountable in case damage has been done willfully or negligence. There is a component of that. Just culture itself is a long lecture, but I think you have just summarized it. So what we take away from here is that I know what I am supposed to do. I should report if I see anything wrong without any fear. The fear should not be that if I do something, I will get some work. It is not that. The work that you get is most probably to help you to learn. If you look at it as a learning experience, then you are not afraid anymore. And believe me, we all remember our mistakes more than all the learnings. If whatever failure I had in my life, whatever mistakes I did in my life, I don't think I will forget them that soon, because the learnings from there are kind of permanent. We all are human. We can make mistake. But if we fail to learn from those mistakes, that's a crime in healthcare. So that's why learning from errors is very, very important. Yeah. Thank you. Let's
Yes,
move
ma'am,
on.
well said. Yeah, right now the third component is identifying the unsafe condition. Of course, when you understand what is exactly supposed to be done and what is wrong going there, you will automatically be able to identify about it. The thing is that you are empowered to speak about it. That's how it actually, we need to encourage our nurses at the nurses, or whether it's all about not nurses, it's all about the people who are working at bedside, or the people who are dealing the patients on a daily basis, whether it's a frontline staff who's sitting in a front desk. Because this survey actually given me the real pictures or different pictures for same component or same word which we are actually using about patient safety. So when I spoke to my one of the friend just now, just I just connecting this speak up policy, speak up for the safety for that thing to her statement which she given me during my survey. She was saying that when she joined here, she's just a 22-year girl. She's dealing up a daily basis on a different kind of patient. Some patients are very, very, like, she welcome every patient with a big smile. Some patient will smile, some patients are like already they are coming up with some kind of a stress related to the disease condition, or the their their own family member are admitted because of some serious condition. That time she feels like, okay, uh, okay, I need to deal up with different ways with the different people. Talking about the safety, is of course she's also seeing that how people are coming to the hospital, whether they are properly able to speak about the things in the condition which can like which can affect them or their patients, which they are the patients with whom they are standing and dealing with at the bedside. All those things are they able to manage? And she also told me that yeah, I got a safe environment, still there are multiple stranger people are coming to the hospital, but if I see something goes wrong, I have that empowerment right now. After like experiencing 2 to 3 months of this particular role, I can speak about it. I can just point out if any GDA or any BSc staff is coming with a wheelchair without placing a safety belt for the patient, I know that she's done something wrong. Then and there I just speak that please put up the belt. So that kind of a culture I actually assume consuming in me and developing and speaking about the patient safety. Encouraging the report of near miss events, of course, as we always say, is that reporting is important. But when to report? Is it like something harm to the patient, then we supposed to report? No. Whenever we have identified which can lead to an error, which can lead to a harm to the patient, we need to report it. Whether it went to the patient or not, but if it would have went, of course, it had been a very harmful situation for the patient. So for that purpose, we always prefer to report things which is near miss as well, so that people understand, yeah, this was my gap. I need to learn from this gap. Giving a feedback, it is very important factor. Once a person is reporting something, coming to you reporting, and they don't know what has happened after that, so there they will feel like, okay, my reporting is not giving any outcome to me. I don't know whether my seniors has taken any step on these things, whether it will help me to help my patients or my colleagues to be like working in a safer environment. If we are not giving such feedbacks to the towards the people who are reporting or the employees who are reporting, it is actually not fulfilling that reporting factor. So that's very important that we should give feedbacks to the employee, that this is the like the ways our HR usually take feedbacks from the employee. If what is their challenges in the work, if they are not dealing with those challenges, or they are not giving some strategies, or no improvements are coming, nobody will report it. So it is very important that we should take an action towards the things which has been reported. Action is not in like a punitive way, but the the process improvement, which actually will help to improve the organizational setup. Having a interprofessional team perform safety rounds, of course, this is very important factor, because uh, in our hospital there is one more culture. The HR usually go for the rounds. There are people of different department usually check for the whether the people are working at bedside is fine, whether the patients are getting the right treatment and right things are happening or not. So it actually help you to identify anything unsafe is going on, or we should take an action towards it. So this interprofessional teams will actually help together each other to improve things. So as I'm working with the CMI hospital, here fathers are very much into the things of patient safety, as well as they're very keen about their employees. So whenever it comes to reporting things, we are taking it very positively. And here, especially, we will just focus on their training perspective. If any training or awareness was the issue, we should deal it with, so that it should not happen again. The condition should not go wrong to the patient harm or to the self harm, because at the end, if anything goes wrong because of me, I myself also will be having that dilemma, that error thing in my mind, that I done something wrong. That's why this patient has suffered. That's why we always focus. The things should be coming up in a eye in early base, so that we can stop and we can manage things in a better way. Ma'am, on from your side.
Just a few tips for actually action items. The document talks about good catch or best catch. I think a lot of hospitals have actually
Absolutely.
started appreciating staff, not only nurses, who have stopped an error or identified unsafe, practice. So this is very important to appreciate people who are, speaking up on unsafe practices, or they're stopping the error from reaching the patient. So if your hospital has not yet implemented it, it will give you a lot of advantage of people wanting to report, because it's kind of an action which says we'll not punish you, we want to appreciate you when you're reporting something. It can be self-reporting or it can be reporting of someone else. And I would say that when somebody is self-reporting, it has to be double recognition. When someone comes up and says, I'm sorry, it happened with my hand, with my patient, they should be appreciated more, because that is where the safe or the just culture starts happening, when people will start reporting. Coming to the near miss events, it's very classical that, the iceberg. The top of the iceberg is your sentinel event. You
Right.
cannot hide it. Anyway, everybody will come to know. Below that is adverse events. Adverse events, most of the time you will report. But the power of making our care safer is actually lying in near miss, because it is warning us that there is something in the system that we can improve, so that next time it should not reach the patient. So, in all this discussion, please see that the individual is not being addressed. It is the process, and it's the system, and it's the leadership. So it is nice to put everything in place, but it's also very important to empower them to report and recognize them, and then near miss, catch the near miss. This is very important. And one more thing that you can do in hospital is actually have a monthly, session where you only discuss the errors that happened. Allow the team only to discuss why it happened, what can be done to prevent it next time, and then the organization can learn from the front line. We'll be surprised that if you call the people who are involved in the event and frontline caregivers to come and tell us how can we stop this from happening, they will have the answers. Many a times, what happens when something goes wrong, all the senior people sit in one room and start to discuss that, what should be done to prevent this. And in my years of experience, I have learned that is a very poor strategy. Bring the people who are actually doing the process, bring them to the table, talk to them and ask them that what can be done so that this will not happen again. You will be surprised, my friends. Please, if you don't have that system, please go back and implement the system, and also introduce the best catch or good catch, recognition. When somebody is self-reporting, give them another award. Very important. Yes. So that's where people will start identifying unsafe conditions and unsafe practices. Let's move on.
As you just said, ma'am, that we have to ask the people who actually at the bedside give you the more inputs for improvements. Definitely, it is actually a correct thing which we also implemented, because we were having a lot of IPSG errors, and the errors were major commonly happening because that ID bands were not clearly visible to the nurse, so she's not able to check properly, and she makes some kind of errors. But yeah, it was somewhere it is a near miss kind of, so that was a safe side. But of course that happened, and we checked with the nurses, group of nurses we called up, we made such errors, and we spoke to them, and we taken out their input that what is the thing which we can improve, what is exactly we can improve. So they are saying to us that if it is good to have a patient identity board somewhere at the patient bedside, so she just look at those UHID numbers and she can compare with her face sheet, and she can go with the further thing. So that exactly was not here. Now we are just starting with that pilot study. So yes, ma'am, this actually the people who are dealing with the things will give you more uh, inputs regarding the improvement. Okay, strengthening with the system. Of course, the communication is the only key, and the proper structure reporting, if it is there, that actually help us to build up the system in a proper way. So if they are open to communicate to you and they are able to report anything, everything, whatever they are seeing, it is not like they're having any fear to the concern. And if it is happened because of any senior people also, they are so free to share those things with the leaders. It is actually give them a safer thought that we can communicate our improvement plans. Collect and review the data about the common causes. Of course, we investigate the events as we're reporting the incidents in different levels. If it is near miss, of course, it will give you a proper view about that what we can improve here so that it will not lead into adverse event or to the sentinel one. So those kind of harms, we if we analyze and we can conclude and we can get down into a strategy that this is supposed to be implemented so that we can deal up the things in a better way. And building a systematic and a mandatory patient safety education program for staff. That is actually should be a refresher training kind of a thing. That definitely training is a part of a very important key to improve the structure, but those training also should be not like everybody should be trained in the same way, because there are people who are already dealing with the situations. If we go with the situation what is happening at the bedside and we compare and then we give a training, will be different impact on the people who are experienced or those who are running with the patient. And those who are coming new to the system will definitely have a different kind of a projection towards the training. So there should be a proper training programs which is actually be a ongoing thing, because of course a person need to refresh herself himself to deal up with the situation. And it should be a mandatory thing, because at the end you have to give a reminders to the people that this is supposed to be done, then only your system will work properly. Then because the system works when the people around and people inside that system is actually know about why I am doing this stuff, why I am doing these things for the patient safety, then only they will have that knowledge and they will then can communicate the things very quickly and very openly. That's the how we can strengthen the system. Over to you, ma'am, to enlighten more about it.
Couple of practical things again. I was reading a book in that it was written, do you collect data which is easy to collect, or do you collect data that is important to your outcomes? So whatever data we collect, in case if the patient and family is not part of it, you will never know the real picture. So I always champion that whatever audit or quality improvement that you are doing, involve the patient. You want to know how is your hand hygiene? Ask the patient. You want to know if the ID band is being, referred to before giving medication? Ask the patient. If you ask the patient, you will know whether it is happening. But those audits take time. And it takes, commitment from the people who are working. So if these things are not being done, then all this GAN, they are all GAN. So audit with purpose and connect it to the outcomes. Now, when it comes to training, you had a very good point. Different people needs to be trained differently. So I have one word for that, outcome-based training. So when I was in hospital, I used to tell my educators, I really don't know how many hours you are training, what all you are training. But when I go for rounds, if I see the things right, your training is good. It is effective. If things are not right, that means it's not effective. One quick thing, JCI, NABH, everyone says that just for clarification to everyone, the patient ID band has to be on the patient. It cannot be even on the side rails. So when your friend line people say that put some big board there, it is okay to give it as a supplement, but it should not replace ID band. Because ID band has to be on the person. I'm just clarifying because, somebody should not think that's a good idea, we can use that. No, it is just one more thing for them to refer, but there has to be a legible ID band on the patient to identify them as them. And this is a standard that we cannot change. And this is very important because otherwise tomorrow somebody forgot to update the board, then
Yes.
will get Tankam's medicine, right? It can
Yes,
happen.
yes.
So just take a
Oh,
note of it. Okay, let's go forward.
surely, ma'am. Okay, to the assess and continuously improve the safety culture. We need to assess it as we just now ma'am has said, the audit actually need to be a real based. It should not be only the paper based thing which you are just doing it for the checklist. It should not be like a tick list. It should be actually done and checked, and then you are planning to do it. So for that, of course, we need to see that the committed error is actually happened because the person was failed to follow the process, or it is happened because the person don't want to follow it. Is it should not be like purposefully they are committing the errors, because as we know, we are dealing with different kind of a nurses. We are come to know across that whether that nurse is actually forget, and that was not because of purposefully she forgot, but there is something like she is busy with multiple patient and she's just a very new nurse, a very newbie into the system, coming up with the very fresh mind, and just now we just trained her and taken her into the role, and she met with some error. I just remember one incident of mine, like one of my fresh nurse, she was working, we actually, as I said, we assign a preceptee and preceptor. So the preceptees actually need to assist the preceptors for their work. So of course they are not administering the medication the time when they are supposed to be in the preceptor period. So she usually helping the preceptor, and by mistake when she's just giving the ampule to her, and by mistake that ampule broken and fell down on the floor, and it was broken, and it was antibiotic which is actually costing some thousand rupees, and she's very much anxious, like it did not happen because she purposefully thrown it or something. It is by mistake it happened, and she was very fearful, like whether it will cost me, or whether they will say that I'm a poor nurse or something like that. So we just dealt with that situation. We told her it happened, but it is not because that you wantedly done that. It's happened because, yeah, of course, there is something like by chance and by mistake it happened. So this is just an example, not related to the errors, but where some, like how the nurses usually recognize that whether I done a something wrong thing, and it is not purposefully I done. It is actually happened because there was a complex system which I am unable to understand, which actually made me to do such errors. The most important part, blame free but accountable. We should create an environment where it is non punitive. As we discussed earlier, also in our other components, creating a non punitive environment is very important so that people should trust in you. They can very open uply, they can report the incidents, and they feel it okay. If it has happened, also, it's okay. You need to change it and you need to improve yourself so that it should not repeat again in the future. That's how we should work, and that's how we should tell them about when they're coming up with such kind of errors. Because I am the as a nursing superintendent, I have actually this is a very important role. I deal with my nurses who's coming up with different errors, different kind of errors, and we have to deal with them with emotional stuff. We have to tell them very the specific things which they supposed not to deviate from. Then actually it will help them to understand the process in the future so that they should not repeat it again. So it is very important to clear these things in the both the areas, that to the nurses as well as to the dealing people, the head nurses, that how to deal with different kind of nurses so that they understand the process very clearly, because we need to prevent the errors. Yes, the good catch thing, which already ma'am has given a very enlightenment, given a very explanatory thing, that of course if you appreciate people, they will capture the thing, they themselves will come and report the things. And this practice usually it is happening in our hospital as well. If the people are capturing the errors, capturing it in a very fine way, we usually give an appreciations to them. We are appreciating, we are having different award ceremonies as well, in which one of the part of this is the good catch, where quarterly which is happening. And also in my central training in my hospital, the central training, we usually appreciate the people with the good catch, and there are multiple new nurses and a different kind of experienced nurses coming up with the initiative. They are not fear of reporting anything, they are actually checking the process how they learned it. So that somewhere it give a satisfaction. Yeah, still we have good number of some kind of a culture we have built, that the people are following the process. Then of course the developing a internal communication plans around the safety goals. So how comprehensive are communication plans, how we are communicating with the people, how we are telling them about what exactly the safety goals, the IPSG goals, how to maintain those goals with the patient, and how we can improve our structure in a better sense, and it will help us to have a safe patient environment. So this is actually the continuous process which actually help us to improve the safety culture. And of course it is a continuous ongoing program, because ongoing thing, because patient safety is always have new challenges, then you deal with those new challenges, you will end up with different challenges. So this is like ongoing thing which we need to understand, which we need to develop our strategies in a different aspects, in a different scenarios, so that different kind of a people who is dealing with patients can understand this better way. And also they feel it, yeah, this is my responsibility, I am accountable for my patient, whether I am a BSA, whether I am a nurse or housekeeping. If I am dealing with my patient, whether I'm a front desk staff, or even that I'm a security, I need to know that, yeah, IPSG or a patient safety. When we talk about IPSG, everybody is having that, there are 6 goals, I have to take care of such goals when the patients are there. So that's how we have to develop it and continuously improve our safety culture. Over to you, ma'am, on this process.
Yeah, we have discussed all the points before, also, it is coming again. I would only give a couple of practical tips. One is that, of course, we talked about good catch, blame free but accountable. Just a word on IPSGs. They are called as international patient safety goals because if we focus safety of those 6 domains, lot of safety is then assured for the patient. Okay, apart from that, there are many other areas that how hospital has to get into. So be little aware that there is a common practice. When something goes wrong, put one more form and give it to the nurse to tick. So this takes me to an experience I've had some years ago when we started with all the bundles and everything. So the group sat down comprehensively, looked at the bundle which is recommended by CDC. We put points which where our people they fail to do. We put those points in the bundle, and we send those checklists to the hospitals. And the expectation was that this infection control nurse and the in charges they will audit the compliance of the bundle components. But when we went to the hospital from the corporate, we found all those checklists are in the file. Just like you mentioned, they all became tick list. I fail to believe when I do ICN program, I fail to believe why this checklist is in the file. Why should the nurses be ticking it? There is no need. They have to do it. And somebody has to check that it is being done, either talking to the patient or directly observing. The practice is what is more important. It is not that adding, documentation after documentation. So now today I was reading about the guidelines for MRSA. Okay. MRSA, the moment we say, everybody will talk about contact precaution. So now the experts, again, evidence, what they are saying is contact precaution is okay, but that is taking away the focus of the horizontal safe practices like hand hygiene, environmental hygiene. People are forgetting. There is no point when you do a contact isolation, you're wearing gloves, you're wearing gown, but you are not doing hand hygiene, your environment is not taken care, MRSA will anyway go. So this is what is very important to know, that when we practice something, what is going to affect what should be known by the leaders. There's a cause and effect to see. So we should not be jumping and saying, okay, let's put one more paper into the file. I know for accreditation, a lot of documentation is required, but is it what is mandated is being documented, or are we over documenting it? It's better to do the proper audits with results. Okay, let's move on. I think our time is getting
Yes, ma'am.
over. We need to hurry up a little bit. Oh, okay.
Yes, ma'am. It's basically about the role you're gonna discuss about the leadership role.
Okay, you can move the slide. I have already,
You want to talk
Sure.
about the points, ma'am, or should
No, no,
I?
I'll just leave it there. I'll just give a little bit, uh, you know, oversight on that. It is not the quality department, it is not the nursing department, it is not the ICN's job to ensure clinical safety of the patient. It has to come from top. This is very, very important. It has to come from CEO, it has to come from COO. If it's not happening, I would request the nurses should assert upward to say that we want you to pay attention. Champion process improvement. The leaders are expected to give their time, attention, and focus. I've had so many experiences where nurse leaders they are aware of numbers. Like if I ask a nurse leader, what is your happy rate? They will tell 1.2. I said, what? What is that 1.2? 1 what? They are not able to tell that it is 1.2 per thousand patient days. They are not aware. So if they are not aware, how can they champion the process improvement? I'm just giving very, very candid, look into with my experience. So unless they understand this domain well and they champion the cause and they provide necessary resources, ask your frontline people what is stopping you from being safe. Now, very common frontline answer is going to be I have too many patients. It's a standard answer, right? I'm too busy. I had too many patients. So I always used to tell my nurses only one thing. I understand that you're very busy. You have too many patients, but I want you to shout. I want you to shout and say that this is unsafe. There is going to be a mistake. I have this problem. I want you to shout. I think the front line, it's not just speaking up, it is also speaking up when you see that you're in the middle of an unsafe practice. If my nursing supervisor is pulling out a ward nurse to ICU, the ward nurse is not experienced in the ICU. So we are creating a situation to harm the patient. It is not the nurse. I tell the nurses that you can refuse to be floated out to ICU when you don't have ICU experience or you have not been trained. I said, let the supervisor call me and tell me this nurse is refusing to go to ICU. I would prefer that dialogue rather than you going and then, committing a mistake. Unfortunately, when this nurse reaches the ICU in charge will say, oh, you are floating. Okay, bed number 4 is yours. There is no dialogue who asks, thank you for coming. And what's your background? Do you have experience for ICU? We don't have time for all that. So there are so many little things that happens in the environment where we are facilitating these errors happening. And these are the little things that we as leaders, whether you are CNO or a deputy or ANO or you are a supervisor or even in charge, look at the process. Are we doing the right thing in the environment so that the frontline caregivers can do their work peacefully? Do they have the resources? One more question I would like to ask all of you. When the frontline nurse does not get the medicine on time, does she give one call or does she give 5 calls before she gets the medicine? Ask yourself. You don't need to answer. I'm asking all the audience. If you expect the frontline nurse who has got 4, 5, 6 patients to call pharmacy for all the medicine that hasn't come, we are failing that frontline nurse. The process needs to improve where she talks to one person and say, I didn't get this. That one person has to make sure that they ensure that the nurse gets the medicine. I'm just giving some very, very practical tips, my friends, because all these are good to know. All of them, maybe you are aware of all these things. But on ground, are we doing is the only question that I will ask all the nurses sitting here and all the fellows who are here. All the fellows who are here, you all are working in different organizations. Go back and champion these leadership piece to see that you get the right environment environment for your nurses to practice safely. Otherwise, we will be always, chasing our own tail forever, not able to fix the problem. We may not be able to fix the problem completely, but we can definitely improve the situation if we think about that frontline nurse all the time, that whether that nurse is getting the right resources, the right support, the right environment to function. Everything else is going to that little nurse, right? Whether Neetu as a quality superintendent, whether whatever that you are doing, whether as a CNO, whatever I am doing, the doctor, whatever that the doctor is doing, whether the CEO is doing, everything is going to that nurse at the bedside who is caring for the patient. So we need to do everything to make sure that they are trained, they are equipped, they are empowered to deliver a safe care. That's all I will tell on this slide. Let's move on, and I think we are almost there. We can open for any questions. So you go ahead and summarize, Neetu.
So my take-off message from this is like few words which we have discussed is one thing is just culture. We need to create a safe culture for everybody where everybody is free to speak about it. Near miss identifications, of course, reaching to the adverse event or to the sentinel event, better to have the errors identified at the near miss so that we can improve our system, improve our processes so that nobody should get harmed, whether it's a patient, whether it's a healthcare professional who's working at bedside. Third thing will be the catch. Good catches, appreciation to the good catches is very important because then only people have the confidence in you to talk about the errors freely. That is how the fourth word, which actually I say that speak up without a fear of having any punishment, without a fear of having anything goes wrong with me. I have that confidence to speak about the things very clearly and very openly in front of the people, the senior people who are working with me. Even I have that empowerment to speak about something goes wrong. Okay, my patient should not be touched by without hand hygiene, or my patient should be dealt with. If it is a particular medicine need to be advised, whether I need to confirm that it is, should not have an allergy. I can stop the doctor. I can ask the doctor, please do check, verify the prescription, or I can have the full-fledged responsibility or accountability and also the empowerment to stop somebody who's taking the patient without a belt. Such kind of a things need to be developed. So then only the safety culture of safety can be in every aspect, in every position. That's all from my side. I'm over to you for the summarization.
Let's go to the next slide.
Yes.
And
Yeah,
we
sure.
will stop sharing. So, friends, I will tell my piece in a minute. So, we all are here because we are committed to patient safety, and we are because of our patients. So, thank you so much for being with us today. And so, a lot of points about culture of safety has been discussed. This document will be shared. I mean, in the Annie members group, we will put the PDF up in case anyone wants to deep dive into the document. There are a lot of good points, very beautifully, delineated there, that who needs to do what when. A lot of points are there, but it takes effort from all of us to put them into action. These webinars are only going to help to sensitize all of us to do more for patient safety. And I'll take a moment. If anybody has any questions or any comments, please, you can. I don't know if any office bearers are here. We would like to hear from you. I'm not very sure if anyone is here. So if anyone has any question or comment, please join, and you can share your views. Yes, Amita?
Ma'am, good evening. Neetu, congratulations for such a informative and such a wonderful talk.
Thank you. Thank you so
You
much.
did it well, very nicely. We had a very nice talk. And I'll tell you, it's not easy what you told about, just culture. I've been doing this study and, trying to induct this in my organization. But it's not that easy. How you talk. Talking is very easy. But getting into that just culture is not that easy, because if you have to make aware, this awareness has to be given to the whole organization. Once you teach the whole thing to the whole organization, then only they will understand why we are doing this. Because when we are doing this just culture, 10 people, 10 or 20 eyes are looking on us, that what we are doing. So first we have to, what I felt, that I have to make awareness to all my departments, HR department, the other the doctors and the senior nurses there. I have to make effort to teach them what is just culture. Then only we can apply it on our nurses. That is the thing which I felt, and I think we can do it, and I'm trying to induct this in my organization. I think if you have done it, congratulations. Thank you.
Thank
Thank
you.
you so much.
Thank
Yeah,
you.
ma'am. Just one line I just wanted to add with the colonel, what she said to me. Yeah, with the experience, of course, you had different departments need to be implement those things, because it's not only nursing who can implement whole thing in the whole organization. But yeah, where we start some initiative, somebody has to start with somewhere. That is how we can play a role. That is only from my side if I say about starting up the things for the just culture.
I think, Amita, I totally agree with you. The culture does not happen only within nursing. It has to be across the board. But as Neetu said, we can start the fire. Somebody has to ignite, right? And I always believe nurses are rightfully positioned to start the fire, to ignite the fire. And people like Amita and senior people, you have the responsibility to give it to HR, to give it to doctors, to champion the cause across. It is important. It takes time, but you can shift the needle slowly. I'm very sure of that. And you very rightfully told, you cannot have a isolated just culture within nursing. But yes, we can make it as a role model department where others will feel that, oh, nurses are doing, then we can also do. Then you have the confidence to say this is what we do in nursing, right? I think that's a very valid point. And Neetu, congratulations from my side too for deep diving into that in this short time. Karishma, you have something to share?
Good evening, ma'am, and congratulations, Miss Neetu, for such a wonderful presentation. It is so well, decoded and added value by Thangam ma'am as always. I just want to share about the appreciation points when we are talking about good catch. So, ma'am, just to share in this forum that we have started giving a thank you card to the people who used to tell their errors or who used to catch the near misses, that I was about to do this, or I did this, and or else I found this, whatever it is. So we have started giving a thank you card, which has been created and beautifully written on notes, that thank you for identifying this and thank you for creating the safe environment for our patients. So because of which nurses in the bedside, they get motivated, like it's kind of positive competition, that how many thank you card I'm getting, or which unit is getting more thank you card on behalf of identifying the near misses. And this has been recognized in even in reward and recognition program. And we could we could forward the nursing staff in a forum that this girl has recognized this thing, for that reason we are giving her a thank you card. And this is also again added in a performance appraisal thing, so people are motivated and encouraged to identify, and they are very interested now to identify, and they ask questions that will it be this incident, will it come in a near miss, or is it already an incident, what it will be. So this culture has been already created, and we are starting a bit. And being a patient safety fellow, ma'am, we talk more about this, and actually not only talking as mentioned in the presentation, we need to walk the talk. So thank you so much for the presentation, and I hope the culture of safety will be able to build, and we'll definitely take forward all the points which has been discussed, and we'll try to implement and put it into our actions, ma'am. Thank you so much.
Oh, great, great. I think this is a call to action from Karishma. Thank you cards have been around for some time in almost all corporate hospitals. Thank you for doing something. But if you make specifically for reporting, near miss or anything, if you have a pre-printed thing, dear so and so, you have been a safety champion, thank you for reporting whatever. And I think that's a brilliant idea. If I was in hospital, I would do it immediately because it
Do you
would have immediate effects. You just then finally, you can club it. Very important point that you mentioned, it is connected to the performance management. It's very important because at the end of it, everybody is looking for their PMS. So if you can connect safety with the performance management, it is already there. But how do you measure that somebody is always a safe practitioner? So when you collect these, thank you cards and say how many one got, how many one unit got, there's a lot of, safe competition happening. So I think that's a brilliant idea. That's a takeaway for today. So thank you, everyone. We have 17 minutes over 8, but I think, Neetu, you were bang on time because I have taken little time. So, friends,
Thank you,
we
ma'am.
will see you in February again. And that time, Lieutenant Colonel Amita, along with Purba, is going to talk about standardizing medication administration safe practices as a large domain. But, however, we will only be discussing what is discussed in the document by Patient Safety Movement Foundation, USA. Thank
Ma'am,
you all. And Jyoti, you have something to say?
I'm Sonali here. Can I say something?
Yes, Sonali, go ahead.
Ma'am, first of all, many thanks to you and Neetu for a very interesting discussion. I just had a question for Neetu. Since she spoke about a novice nurse committing an error, I just had a curiosity to know from her as to what is her experience or anyone who's in this forum now attending, if they are on nursing service side. Do they find the novice nurses in terms of patient safety knowledge or practice anything different that the experienced nurses, and what is their experience about it? Yeah.
So, thank you so much for asking and giving me an opportunity to say about this, Anali, because this has actually touched me that day when I just met that new nurse. She's just now joined and she's very fresher to us. Actually, my whole team is here. Most of the team members are joined this patient safety program or patient safety presentation as well. So, what happened actually? What is the difference between a experienced or fresher nurse? Experienced nurse, no, okay, I committed this error, but it will have that impact that I need to improve in that particular process where I'm deviated. But for a fresher nurse to understand that process of our just culture, which we had just talked about, the culture of reporting things and taking out the correct measures, whether they gonna punish me, because she won't understand in one go only that it is non-punitive. My dear, it's just to improve your practices. So yeah, there is a difference of getting a proper knowledge and implementing those things take an experience to understand actually what we taught them in the induction program and to coming up with a fearless attitude towards reporting things. That actually takes time because nowadays the fresh nurses, everybody knows that they are coming up with very rare experience of dealing with the patient. It is like starting from the scratch. We are just starting them, training them and giving them an environment of hospital which actually they're not dealt with during their academics. There's a lot of difference. Still, I always tell this to Tanga ma'am as well. There are still lot of difference between our academics and the the practical things which we do at hospital. So there we, of course, we need to build up a bridge between both the things so that the nurses who's coming from the as a fresher also should understand that yeah, if something happens that is I need to correct somewhere or a process need to be correct.
So what would be the bare minimums of patient safety you think that the academics should really give to the students, given that you understand that the curriculums are power packed with multiple subjects, and academicians don't have control over it because it's
Right.
prescribed by INC. So if
Right.
we come down with these are the bare essentials, and a graduate novice nurse should really know. Could you, I mean, just list them out? Uh,
Can
Yes,
I
ma'am.
yeah,
step into that
yes,
because
yeah.
it is off the cuff, I can tell. Uh, Infection prevention control, the basic,
Mm.
the standard precautions, that must be clearly known to them. Biomedical waste and all those things should be very clear in their head. And then comes the bare minimum infection, IPSGs, at least IPSGs, if they come to know these other domains, where things can go wrong, what we need to do in an experiential manner. And I'm very sure that these things can be injected within the curriculum at when those topics are coming up. When you're doing the med surge, you can talk about patient identification. Medication administration is coming very easily. Identification of the patient is everywhere. So you can bring those stories, and you can bring those stories of error, how things go wrong. They should be aware that, it's almost like, when you are going to learn to drive a car, if you don't know what can go wrong when I drive a car, I will not know when it goes wrong. I'll be like, I don't know what happened to the car. I'll step out and stand. There's a lot of jokes around female drivers, no? Oh, no idea. Gaadi utha ke jati hai and she has no idea. So something like that, I would always say, storytelling, simulation, experiential learning, and, lot of videos which are available around these topics, they can self see. So then now there are a lot of research evidence coming out that whether it is a procedure, whether it is a domain, or anything that they view multiple times, they tend to remember and they will do it right. So what I feel is, rather than crowding the academicians, putting everything, take some of it outside the class and say, okay, you watch this video, then come back and we are going to discuss, or we are going to do a role play. Youngsters are very curious about doing things themselves. So what we have seen in Annie, when we have invited students and young nurses, there was only one voice that was coming. Respect us, speak to us, involve us. Three basic things. It is not only for services, even for academicians, So giving them that experience, nothing new only in nursing, by the way. MBBS pass out doctors also have no idea. Engineers in millions come out, they have no idea what engineering they have done. We are aware of this. So I think the modality of training can be a little bit more creative. I think that's what I think, injecting these practical things into at the right time inside the curriculum very smartly can translate better results. This is what I feel, because if they know IPSGs, if they know infection prevention, the wish list can be very long. But I would only request the academicians, try with one batch with these basics and see how they are turning out. Call up the hospital where they went for interview. Sonali is coming from a very prestigious, academic, setup. But still, it is nice to follow up and see that when we did this intervention, did the students, pan out to be better? Were they more confident during the induction? Did they perform better? Because it takes a little bit extra time to follow up the students to see how did they shape up when they were trained in this manner. So we need champions from academics, Sonali. And out of all these people, you are the only one who is here interested to think about, culture of safety, because we are training them to be safe nurses.
Yes, yes.
We are
I
training them to be safe nurses. That's the end of the
completely
story.
completely agree with you, ma'am, and thank you for your inputs. And as always, I always see that passion and the practicality of tips. It's never theoretical when it comes to you. I have no words how really to put it in words. That much appreciation as to how you really just nail the things as to how things happen on ground and what really needs to go right, what really needs to happen. I think that's really very essential at whether it's in academics or it's in bedside, even more important there, I think. So thank you very much for creating this platform and these kind of discussions.
Thank you, Sonali. We hope to see you every month back. They're all different domains and they're all evidence-based practices, from the foundation. It'll be a great idea. to take this document and, get your BSc final years and MScs to go through this document also and have just a discussion around the document so that they understand the environment even better. And maybe MSCs should be going and taking some sessions for the freshers on these domains, that way there's a peer learning that is going to happen. So,
Yeah.
ideas popping up. If
Yeah,
I'm
they
right.
have some teaching practice, and also we'll try to inculcate these topics into their teaching practice same kind.
Great,
So
great. Thank you.
yes,
Okay.
thank you.
Jyoti, you want to say something before we wrap up? Jyoti is
Yeah,
on
ma'am. That was a nice presentation, Neetu. And yeah, as we were talking about culture, as Amita ma'am also well said, that having that culture change in an organization is very hard because people acceptance. We are also in that same phase of transition, people acceptance, and then all of them talk about culture change.
Right.
But when it comes to implementation, that's when we see the challenges and a lot of resistance from people. That's where I think all of us are there to bring that change and hope that we put this into practice and we be that, we have to start somewhere. And I think we are starting somewhere and then we see the change, hoping to see
Great,
that.
great. I'm seeing all safety champions here in all our fellows. There is a lot of excitement, and thank you so much, Neetu. You initiated the thing, and looking forward to Amita and Purba's session next month. And Saujanya, you're on the video. Do you want to say something? This is the last, and then we wrap up because we are little ahead. I mean, we have taken extra time. We said
Hi, ma'am.
one.
Good evening and
Yeah.
good evening, everyone. It was well presented presentation, ma'am. As rightly mentioned, the thought process in my mind. Very difficult to implement, but the challenges are everywhere, every time, which we are going through a day-to-day practice. But as we started today in the new year of 2024, so somewhere we started with this culture of safety. Let me implement from the tomorrow about the safety culture in with my nurses. So probably that change which we are going to start up in our organizations, ma'am.
Great. Thank you so much, everyone, and God bless you and be the safety champions for our patients. They deserve it. We cannot overlook that. So thank you so much once again, Neetu. Congratulations. Well done.
Thank you, ma'am. Thank you so
Look
much.
forward to the future sessions, and all of you welcome back in February. You will get to know through notification when and where. Okay. All right. Bye-bye, everyone.
Okay,
Bye,
have a
ma'am.
good
Thank you.
night. Take
Good
care,
night. Good
everybody.
night.
Thank you.
Bye. Bye.